Okay, so I've got with me again today someone who'll be known to many of you, which is Dr. Martyn Pitman, obstetrician and gynecologist. So if you haven't seen the interviews that I've done with him previously, we've interviewed Martyn on a few occasions now, both looking at general issues related to the Lucy Letby case and also specifically with regard to the obstetric information of some of the infants. But today we're going to be asking Martyn some questions about obstetrics, about the background to the infant, about the hospital, and just some general questions as well. So first, I just say hello to Martyn and thank you for joining me.
Hi, Chris, and thanks for the invite back, and Happy New Year to you and to those who are viewing this podcast.
Yeah, thank you, and same to yourself.
Thank you.
So this is going to be a broad-based thing. We've got lots of questions. I put the feelers out to get some questions, and I got loads. So we're not going to even get close to getting through all the questions today. So we'll just start from the start and see how far we go. So the first question that we're going to ask is, Lucy Letby's conviction was based on her involvement with neonates. Why do you think it is so important to consider the maternity obstetric history of each of the cases?
That's a good question, and it was that was partly why I got initially so interested and involved with the whole Lucy Letby case, Chris, because the more I looked into it when the judgment came out and she was convicted, the more astonished, surprised, aghast I was that there was so little information out there about the involvement of other specialties other than Dowie Evans's input as far as the neonatal and paediatric side of things was concerned. And initially, I kind of didn't believe it. I thought, well, there must have been surely intensive review of the maternity and obstetric history of particularly the cases that went to court, but also the other cases. And I guess it's based on my professional background, because when you work in a specialty, particularly obstetrics or neonates, every day of your professional career, you are reminded of how critically important it is that you liaise with your counterparts. So for me, I had a very close working relationship with our brilliant neonatal colleagues in Winchester, and it worked both ways. And I think it was because of that that you optimize the outcomes of your cases, really. And without that critical interaction, things can very rapidly slide. And it was also partly based, I think, in the I think I mentioned this before in one of the previous interviews that we did, that I felt or continue to feel very fortunate that when I went through the early stages of my obstetric training, part of the requirement back then, and it isn't the case now, but I always recommended trainees that worked under me to pursue this, was to spend some time working in the neonatal unit. I think for any obstetrician or fetal medicine consultant, it's well worthwhile spending time on a neonatal unit, because then you see it from the other side, and it makes you far more appreciative of the stresses that they're under. And if they're really busy, and you then just decide to do for instance, maybe a semi-elective but premature cesarean section, and they're already busy, and you haven't prepared them for that, then that's a real nightmare for them. So I felt very fortunate having done that, and I think it was because of that that I realised the more I looked into the Lucy Letby convictions that it was astonishing, unbelievable, the paucity of involvement from the obstetric and maternity side.
I mean, it's even less than a paucity. Like we know now, it's zero.
Yeah, and is any I think any medical professional, be they doctor, midwife, nurse, particularly anybody working in obstetrics or neonatology, will realise that the fact that that was the case is astonishing. That a case of this magnitude can get into a court, can go through all of the preliminary checks that led to the decision of the CPS to pursue a conviction without a forensic look through the maternity history and obstetric histories and delivery histories is frankly astonishing. And I don't blame the jurors for not realizing that. I think the fact that the judicial system and the CPS can allow that to happen is terrifying, really. And if you look at it, we all know now the reason why, and I was going to come onto this later on. There may well be questions about this, but it wasn't through want of trying. We now know that the NCA, National Crime Agency, when they were informed what the Cheshire Police were doing, they tried. I mean, there are documents that are available in the public domain now that prove that they approached the police to say, we're obviously very interested and supportive in what you're doing, but we would recommend the initial trawl of the clinical cases that they're concerned about should include an array of different experienced professionals, including, interestingly, obstetrics, senior neonatologists, neonatal nurses, statisticians, paediatric endocrinologists, etc., etc. And of course, that never happened, astonishingly, despite their recommendation. And why didn't it happen? Well, because the sole self-presenting, in inverted commas, expert that presented to Cheshire Police, when he was consulted about this, hoodwinked the Cheshire Police and informed them that none of that was necessary. That he was able, skilled, and qualified to take all of that on. So it never happened. So Evans managed to convince the police that none of it was necessary. Now, what we need to consider, it's too late now, but just imagine if that panel had been convened. So if you'd had, say, Jim Thornton on it, a senior, very experienced neonatal nurse like Michelle Warden, Jane Hutton, the statistician, a paediatric endocrinologist. So every person that the NCA recommended was critical to assess these cases before deciding where to go. If that panel had been convened, in my mind, it's inconceivable, particularly if there was any other neonatologist in the world other than one Dowie Evans from Carmarthenshire. It's inconceivable that Lucy Letby wouldn't have enjoyed a nice Christmas at home just now, rather than being locked up at His Majesty's pleasure. And that's terrifying. It's terrifying. So so I think any medical professional would realise that failing to look at what these poor mums went through that led to the decision of their babies, given that they were almost without exception complex pregnancies. You've only got to look at the gestation and size of the babies and the albeit restricted medical history that is available in the public domain to realise that these weren't straightforward pregnancies. Many of them were very, very far from it. So Dowie Evans' view that was pervasive right throughout the trial, that these are all entirely well, stable, uncomplicated babies that were doing brilliantly, is nonsense. Absolute nonsense. And I think if the reality had been looked at before the decision to go for prosecution, but even if a Jim Thornton level of experience, caliber obstetrician was called to give evidence in the actual trial about some of these cases, I think the jury would have been given a very, very different stance on these babies. That these were not unexpected collapses. They were complicated pregnancies that, and some of them, which we'll probably go on to discuss later, wouldn't have come as any surprise to the obstetricians because of what they picked up antenatally. So it's a travesty. It's an absolute travesty.
Yes, I just want to ask you a follow-up question about Dr. Evans, really. So I think we can all agree that what has happened with him hand-waving other experts in other specialisms, the RCPCH report he waves away, and other things as well. I think we can all agree that's wrong, and I don't think you need any medical qualifications to know that. it's pretty obvious that you'd need people across multiple specialities, really. Um, is there any conceivable defense for this action? Is there anything you could possibly say in his defense as to why he's done this?
If you don't mind me addressing that from the two sides, then yeah, it's very, very easy, I think, from both sides to explain it.
Okay.
From his perspective, yeah, it's very easy to explain. There's two reasons. The first one is that I think he clearly decided within 10 minutes that there was malfeasance, looking at Baby O's notes within 10 minutes, the famous within 10 minutes over a cup of coffee when he was sat in Cheshire Police Station. He decided there was malfeasance. Then he had to come up with a potentially plausible medical explanation for them. And my own view is, I suspect, given the amount of medical legal work he'd done throughout his career, that he had waited to be able to use the potential clinical mode of death of air embolism, and this was his opportunity. And he knew damn well, as every medic does, that to confirm or refute a diagnosis of air embolism is next to impossible. And he knew that. So his concern with recruiting other experts was that they would have challenged him, quite rightly. And they also, from the obstetric side, would have said, well, hold on a second, this baby wasn't stable, it wasn't well, it was premature, it was severely growth restricted. So why are you ignoring the myriad of other far more likely plausible explanations for injury, morbidity, and mortality for these babies, and instead opting for the absolute lowest probability, dreamed up etiology of malfeasance, which was air embolism? And the other side, I hate to say it, is a financial one, in that by restricting the input from other experts at that stage, he was diverting the money that was available for the investigation of these cases straight into his own bank balance, and that would have been diluted. And the investigation wouldn't have taken anything like the amount of time if other experts had been recruited, because it would have been kicked into touch. From the flip side of it, so from the those of us who are concerned that the evidence doesn't support Lucy Letby's conviction, then no, it's completely indefensible. And all it highlights, from my perspective, and I think most people looking at it from the could Lucy Letby be innocent's perspective, is what it highlights is that individual, Dowie Evans, his level of clinical arrogance was probably the only thing that actually superseded his level of clinical ignorance, which is quite astonishing, really. But I think it's very difficult to claim otherwise. So I think you can explain it. You can explain his actions from his side, because he was adamant, despite the complete and utter lack of any objective evidence to support his theories, that this was going to end up in a conviction, and it gave the Cheshire Police Force what they needed to see that through. But from the perspective of the other side, it's completely indefensible. I don't think you find any other professional, particularly medic, who would say that a neonatologist giving or completely dismissing the relevance of other specialties is anything other than completely ignorant. So no, I can't support that at all.
Yeah, I mean, obviously I'm of that opinion, but I just, I always try and see things from both sides and try to come up with some reason, some justifiable reason that this would happen, other than one of self-interest. And I can't see one. So I just wanted to see if you could, and I don't think there is.
And it's interesting, as your array of interviews have progressed, you look at the positions and the caliber of the people that you've interviewed, and from whichever angle you look at it, whether it's Steve Watts from the police side of things, Jane Hutton from the statistics side of things, you've interviewed radiologists, you've interviewed senior neonatal nurses, you've interviewed neonatologists, you've interviewed and they're all saying exactly the same thing. That this was one guy who stepped way beyond his not only his level of expertise, but the remit of his position as a court expert.
And it's interesting with that in mind. There's now this new case where he's allegedly done it again in this shaken baby.
Oh yeah.
I
How
mean,
many
I
more
mean
cases are out there
that
that
doesn't
haven't?
come as a surprise, does it?
No, because well, it doesn't. No, because it's obviously how the guy practices or has practiced. And the concerning thing is, how far does this go back, and how many other cases are out there that predate social media, predate everything being digitized, and they're just sat there with poor grieving parents that haven't had this level of input. So yeah, I think it is potentially going to open a, if it hasn't already open a massive can of worms.
Yeah, I agree. Yeah, so let's ask you another question about obstetrics. So, how much information could have been found out about the condition of neonates at birth from the obstetric scans and mother's antenatal notes and medical history that don't appear to have been included in the evidence presented to the court? I mean, we can say they weren't presented.
Yeah, again, a very astute question, and the answer to that is a vast amount. And I'm still unclear from the information that's available about how much of this was either seen by the prosecution, and I'm pretty certain that how little was seen by the defence. And it's interesting still that I am not seeing anything about any plans to release the maternity or obstetric notes, even now. It's a critical piece of the jigsaw puzzle, and it's back to what I said in my opening statements, that critical, intimate working relationship between the obstetric team, the maternity team, and the neonatal team is fundamental. We kind of, in a way, we do our work, and then this is an oversimplified view of how you work in our specialty, but we do our bit. You make a decision. Normally, you get it right, and then you pass over the results of the mother's brilliance in producing and nurturing the baby, but you hopefully make the decision to call an end to the pregnancy at the right time, so that you deliver an optimally conditioned baby for the neonate. So the issues around the decision process for that are fundamental. They're critical, and a lot of that will determine how well the babies do once they're delivered. And there's nothing more. One of the there's so many bits about our career, particularly I can talk of my own experiences in obstetrics that are so rewarding. But when I think back through my career, prematurely ended, but the biggest satisfaction you get is gratitude from the parents. If you've looked after parents that have either had a really stressful pregnancy and you play a small part in producing a good outcome for them, that's incredibly gratifying and satisfying. Even more so, perhaps, if you've had somebody who's lost a pregnancy previously, and then you're given the privilege and honour of looking after them in their subsequent pregnancy, and you guide them to a successful outcome there. So you replace tragedy and upset with positivity and a good outcome. That's great. The other thing that's really reassuring is your whole clinical life is about making decisions, and in obstetrics, probably one of the most stressful specialties in medicine, because you're dealing with at least two, sometimes three, sometimes four people's lives, the mother and her baby or babies. So you're making pretty life and death decisions, and most of the time you get it right. So another satisfaction of the role is when you make a decision, and sometimes they're difficult, sometimes you mull over it for days, and then you make a decision to maybe deliver a baby, and how you deliver the baby and when you deliver the baby. When you then get feedback from the neonatologists to say, well done, you got that spot on, and you got the diagnosis right, you got the birth weight right, and that baby didn't have much longer left, so you gave that baby to us in the best nick possible. That's incredibly satisfying, because you're then getting commendations from your professional colleagues. So yeah, the details. So going back to the specific question, the obstetric scan's critical, because you need to know, or for these cases, you need to know, was the correct decision made to deliver baby X at 28 weeks, and was the baby as growth restricted as the obstetric scans predicted. And there are new, for me, looking through what is available about some of these cases, it's intensely frustrating, particularly with the triplets, with some of the growth restricted babies. You think, well, how accurate were the scans? Because most of the babies that were delivered because they were small will have had multiple scans during the antenatal course. So, because you very seldom make a decision to deliver a growth restricted baby. So by that I mean a baby that hasn't hit its growth potential, and baby C being a very classic example of that. So how accurate was the scanning? Was it the right decision? Did they get this spot on? Did they prepare the mother and the baby for this optimally? Classic example of that is about, and we've discussed this last time, it'll come up again today, about were steroids used for their maximum efficacy? Were they given? Were they not given? When were they given? Were they used optimally to prepare the baby for that transition from water breathing, amniotic fluid breathing inside the mother, into air breathing, as we enjoy? So, huge importance, and all of that would feed into how well these babies were. Were they clinically stable? Was their course, once they entered our world, likely to be straightforward? Were they as well, stable, unexpected to deteriorate and to decompensate and crash, as Dowie Evans repeatedly stated, most of which I think is garbage? Or could some of this have been protected? Going back to baby C, which we'll cover probably a bit later, that baby was supremely compromised. And I'm not sure that, well, in fact, I am sure that the details of that weren't really demonstrated in the trial. And Dowie Evans' theories about how that baby tragically met its demise weren't challenged by that poor little baby's antenatal course and what preempted its delivery. The antenatal notes and histories, are equally important, because, and again, I would say from this, the 2 chats ago when we discussed twins A and B, again, huge concerns and discrepancies and lack of information that's been able to be gleaned from that mother's history about, well, what exactly did that mother have, and how much of that was known by the obstetricians, and most critically importantly, in view of what happened to those babies, how much of the known medical information about those babies and what they may have inherited, if you like, from their mother was passed on to the paediatricians. It appears very little. So yeah, I mean, that's a fundamental part of why we're having this discussion today, and why I think it's of massive importance to Lucy Letby's new defence team that Jim Thornton and as I understand it, the team of 2 obstetricians and 2 materno-fetal medicine consultants are now feeding into her defence. I think that's a huge development, and hopefully, if they get the full records, I think it's going to torpedo a lot of these cases.
Yeah, well, I mean, that's really good to hear. Something I'd like to add to what to your comment is that I've mentioned this in a video recently, but what you have to understand about this hospital is that it wasn't a level 2 unit for very long. It was only a level 2 unit for 5 years. The decision was made in 2012 for whatever reason. Almost certainly, I think we can say absolutely the primary motivation is financial. Whether there were any other motivations, I don't know. There are certainly, I've seen suggestions that there could have been, but definitely financial motivations will be enormous. They always are. And they were only a level 2 unit for 5 years. So when you hear in the court case and at other times people saying, "Oh, we never had any problems before. We never had any problems before," they only had 3 years before these problems. That they actually had problems in 40% of the years they were a level 2 unit. They did okay in 2012, 13, and 14. Okay, they didn't do great. They did okay, and then suddenly they had difficult level of acuity. These twins and triplets, as we've discussed, they had staffing issues and the other problems on the unit, and they absolutely bombed. Then they were downgraded, and then they never will be upgraded again, probably. So
And of
there's
course,
this.
the corollary of that, Chris, is, of course, they were so absolutely certain and remain to be that the sole individual responsibility for the loss of these babies and the deteriorating outcomes was Lucy Letby. Why haven't they? So they cleared her off the unit at the same time as they downgraded. So once she was gone and convicted, so they've actually, in their eyes, not only removed but prosecuted the individual that led to the deterioration. Why hasn't it reverted back to a level 2 unit? I mean, if I was in that unit practicing as a high risk obstetrician, that's the bread and butter of my clinical career that's gone. So you would have thought, from every perspective, obstetric, neonatology, neonatal nurse, midwifery, as it's a very, very different working environment if you're only going to be delivering the lower risk, more advanced gestation pregnancies. And that's not what you train for. And the problem they've got now, of course, is the longer it goes without doing that, they're going to de-skill. So yeah, that's.
Well, I think we can say quite confidently that they're in no fit state to be upgraded, are they? I mean, would it be realistic for them to do it now? It's 10 years since they've been a level 2 unit, and we know the inadequacies that occurred when they actually were a level 2 unit, and now, as you say, they've had 10 years of creeping further and further away from being qualified. I mean, would it even be feasible now?
Well, it would take an enormous amount of effort from the clinicians to demonstrate, and probably a whole host of more appointments at consultant level and at senior nursing levels to demonstrate that they had the skill set available to be re-upgraded, for sure. But it's a question of the necessity of providing the service. How did the other units around there cope when the decision was made to downgrade? Because those babies had to go somewhere. And it wasn't an insignificant number of babies, high-risk babies that the counter suggested was looking after. So that would have been a hell of a problem for the other neighbouring units. So Arrow Park and Liverpool, and probably into Wales, because those mums and babies have to go somewhere. Yeah.
Yeah. So that clears that up. So we'll move on to a different topic now. So, in your opinion, how important was it for an obstetrician to be involved in the court case for all deaths, but especially for the twins and triplets, to give an opinion on the risk of sudden collapse or death in such a baby, especially if very premature?
Yeah, critically important, and I think there's so much doubt, isn't there, and big question mark about the selection and attendance of defence experts in the trial, and restricted to just the trust plumber. In an ideal world, if you could, as a non-judicial, non-legally trained individual, if you could plan the optimum way to legally explore these cases in a trial situation, you would have done what Ben Myers tried to convince Judge Goss to agree to, which was look at each case in its entirety. So you'd have looked at the first baby, and you'd have had the prosecution have their experts, then you'd have had the defence have their side. So the judge and the jury would have been able to see both sides of the story. And in an ideal situation, particularly in the obstetrically complicated cases, and I agree, there is, as far as I'm concerned, an inexplicable representation of multiple pregnancies in these group of babies. Now, that is, of course, explained by the anti-Letby lot, that she for maximum impact, Letby decided to try and take out multiple pregnancies. Is that the case, or were the multiple pregnancies delivered in a worse condition for some reason? And I don't think that's been established. So sure, absolutely, but that would only have worked if the maternity and obstetric notes and scans and delivery records, which is obviously critical with the triplets OP and Q, were available to both sides, the prosecution and the defence. And of course, that was deemed not necessary by Dowie Evans, so it never happened. So I can't help but think, if that did happen, if each of the, if there'd been obstetric involvement beforehand, it would never have got to court. But if you'd have had a renowned, very experienced obstetrician going through what I think will be uncovered when these notes are reviewed, then sure, I think it would have given a completely different slant on many, if not all, of these cases.
Yeah, something I'd like to add there is regarding this theory that Lucy targeted the twins and triplets. Obviously, completely speculative nonsense, but leaving that issue aside, don't forget that Lucy was convicted on child D. So I think I'm right in saying child D is the only full-term infant in the court case. And this infant, certainly, the more that I've spoken to healthcare professionals, the more that I've spoken to informed people, the more they've made it clear to me that the standard of care was abysmal and that this was a very preventable death. So that case could have looked very suspicious, because that child shouldn't be dead. Frankly, it's a crying shame that has
I think
happened.
that's spot on, Chris. And we haven't really focused on child D much in our previous discussions,
Mm.
but I'm more than happy to today. And I think you're absolutely spot on. Yes, that was a far more advanced gestation baby, and there was clearly, from the limited amount of information that is available, there was clearly concern from the trust about the medical legal consequences of what happened with that case from the maternity and obstetric perspective. For those of you unfamiliar with the case, this was a baby where the mother had very prolonged pre-labor rupture membranes. So for the non-medics, obstetricians, midwives in the viewing audience, the normal situation when a mother goes into labor is contractions start, the cervix, the neck of the womb starts to dilate, and then sometime during normally the first stage of labor, which is when the neck of the womb goes from being tightly closed, so it sort of maintains, if you like, the continence of the uterus that keeps the baby in for 40 weeks. All of a sudden, it has to then dilate to 10 centimeters to allow a sizable baby to come through. Normally, during that process, the waters will break. So the baby is surrounded by an amniotic sac, like a balloon, inside of which is the amniotic fluid, which is predominantly the baby's urine. So that's called the waters. So the normal situation is contractions start, neck of the womb starts to dilate, and the waters break, releasing the fluid, and you get a gush of fluid. In baby D's mum's case, she had pre-labor rupture of the membranes. So basically, she had minimal contractions, and the waters broke, and that was confirmed. It wasn't in dispute. Clinically, it was obvious. So she was draining fluid. Now, from the obstetric midwifery perspective, as soon as that happens, the clock starts, or the calendar starts. So once it's confirmed, you ask the mum what time it happened, and then you make a note of when 24 hours hit. And the reason for that is the membrane, so the sac of fluid around the baby, performs numerous functions, but essentially the important ones are twofold. It keeps the fluid inside the uterus, which is critical for the baby's development, particularly at premature gestations, because the babies breathe the fluid in and out, and that fluid allows the baby's lungs to expand and to function. So it's critical for the baby's development. It also allows the baby sufficient room to extend and flex its limbs, so you don't get what are called contractures. And the other critical function it performs is to keep infection out. So at the neck of the womb, so the bit that's nearest the vagina, the membranes, if they're intact, act as a really effective prevention of ascending infection. So even if there are bugs in the vagina, normally the membranes will keep them out. So if the membranes are breached, if the waters break, then you have a potential route of ascending infection. So bugs in the vagina can go through the neck of the womb into the uterus and can make the mum unwell. So you can get what's called a chorioamnionitis. That's an infection inside the womb, and that's critically dangerous for the baby, depending on the nature of the bug. So most units, and this has been accepted practice pretty much for the entirety of my 3 decades in maternity and obstetrics. Once you hit 24 hours after you've confirmed the waters are broken, particularly with a term baby, you would recommend delivering the baby. So either inducing, so if the baby's head down and there's no contraindication to induce, you would induce labour either with prostaglandins or preferentially oxytocin, a drip to initiate contractions. Or if the baby's breech or the lady's had to repeat cesarean sections, you would do a cesarean delivery. At 24 hours, you would then also start antibiotics, and most units would give intravenous antibiotics. And the specific reason for that is to reduce the risk of ascending infection for the baby. So tragically, in baby D's mum's case, that didn't happen. So they confirmed rupture of the membranes, they confirmed the timing of it, and she was allowed to go 60 hours before she was given antibiotics. So that would have dramatically increased the risk if there were bugs in the vagina to ascend and to infect the baby. And of course, that baby had a pneumonia. The conclusion being that, and it depends which side of the fence you sit on, either the baby died from a pneumonia, which was the conclusion of the expert panel, or Dowie Evans and the Anty Letby crew believe the baby died with a pneumonia. So died from Lucy Letby's handiwork, but it wasn't.
Can I just mention something on that point?
Yeah.
So Colin Morley told me recently, Professor Colin Morley, neonatologist, there's just no way Dr. Evans can say that that the infant died, the
No.
pneumonia wasn't significant.
Right. Oh, yeah, absolutely. But again, it's down to it's like the smoking gun thing, and we heard the smoking gun thing about Ravi Jayaram's claim about finding Lucy Letby red-handed. But this case is the classic smoking gun. You've got a baby that died with that history, which I hasten to add the trust clearly recognised was equated to medical negligence, because they consulted with their medical legal barrister who said the management was indefensible, which I don't think you would really struggle to find any midwife or obstetrician that would support a delay of 60 hours in addressing the situation, giving intravenous antibiotics, particularly if then you get an infective morbidity or mortality, which was the case that. So it's a smoking gun. You had a mortality, you had a causation that prolonged rupture of membranes, not given antibiotics, delayed from delivery, and then the management of the baby postnatally was far from ideal as well. It was delays of giving antibiotics postnatally once the baby was delivered. But no, we'll forget all that and we'll go for Dowie Evans's dreamed up modality of death, which was astonishing. So yeah, there was clearly concern from the trust about the potential of this going medical legal, as I suspect there are from several of the other cases as well. Yeah, so baby D was again one of the cases that I was going to use as examples of why a detailed forensic review of the maternity obstetric history would be enlightening. And also, how did the trust learn from this? Because it's a tragedy whenever you get cases like this, and it's tragic for everybody involved, particularly the parents and the loss of life of their baby. But the critical thing from an organisation is, okay, this has happened. It shouldn't have happened. We've made mistakes. Admit it. Front up to it. Duty of candour and everything that goes with it. What have we done to prevent this from happening again tomorrow? So, and I would have thought something as absolutely fundamentally basic as this, which, let's face it, would be probably a fourth year medical student pass-fail question in a medical student exam. The day after they found out what happened, there should have been directives going around every single employee in midwifery, maternity, paediatrics to say, this has happened. Can we please? Did that happen? I don't know, but it should have done. It's bad enough having an avoidable disaster like this, but not learning from it and putting every single possible step in place to prevent its recurrence is unforgivable.
Yeah, absolutely. So the next question I'm going to answer, but I didn't edit this question out. I just thought I'll answer it quickly. So the question is, why do you think the obstetric histories and the input of obstetric experts were completely ignored by the police and the prosecution? So we know the answer to that question now. The reason is because Dr. Evans told the police to ignore them, basically. We've already been over previously. I've shown in the complete trial, I've shown this to Martyn in a previous interview. Obstetrics barely appear in the court case. It's an incredibly minimal amount, and maternity doesn't appear at all. And we know why, because Dr. Evans told the police, "Oh, don't bother with any of that." As to why the police listened to Dr. Evans, we can't answer that question. We can't answer the question of why are the police incompetent. That's an impossible question to answer. that's a question for them to answer, and they're not talking very much at the moment. So that's the best answer I can give you to that question. So I'll move
Yeah,
on.
and I think is I use this analogy. I think it was in the first session we did, Chris, and I use the Swiss cheese analogy,
Hmm.
um, which is something that crops up in risk management, and not just restricted to medicine and in any area of working life. Um, and most of the time, when you've got repeated decision processes, and every human being is fallible, any human being has the ability to make mistakes. Hopefully, you then learn from them and don't do it again. But um, and most of the time in clinical cases, you get away with it because somebody else intervenes. And if you a mistake that you make is a hole in the cheese. So what you don't normally get in a situation with a lump of Swiss cheese is you get all the holes lining up. And I think what happened with this case, from the moment that probably predated even Dowie Evans, because you still don't really know how and why Dowie Evans got involved and went up to Cheshire to present his services to the police. But I think what happened in this case is the classic case where there were lots of errors, there were lots of Swiss cheese holes, but Lucy Letby was remarkably unlucky in that astonishingly every single one of these holes lined up. So you had a lump of cheese and you could see straight through the middle of it because all of the errors, all of the holes in the Swiss cheese lined up. And what we don't know is why. So yeah, why did the police listen to Dowie Evans? Why didn't they say, yes, but hold on, we need to get an obstetrician? How keen were they to secure an immensely high profile conviction?
I have my suspicions, but I can't confirm those suspicions. So
Yeah.
um, I can't say. The police don't even operate the Cheshire Police don't even operate their Twitter account, as I pointed out many times previously.
Mm,
So they're not likely to talk in the foreseeable future. So
no.
let's move on to the next question. With the information that you have been given access to and is therefore available to the public, are you able to give examples of some of the cases that back up your view of the critical importance of declaration of important maternity obstetric details of the cases?
Okay. Yeah. So I could spend the whole evening going through issues, but I'll streamline this to, and I'm also not going to go over what I've highlighted in the previous discussions that we've had, because I think I would encourage anybody that hasn't seen any of our previous sessions to go back and listen to those, because some of this question would be more than covered by them. So I'm not going to do all of the cases, but I'm just going to give some examples, some of which we've already covered. And we'll go through them. I'm just thinking from memory from alphabetical order. So if we start with the first case, twins A and B, and we chatted through this, I'm not going to go through it in all of the detail, but there are huge concerns about this case, about the not only the apparent lack of detailed medical information that was made available to the court and was presented to the jury, and the way that was presented to the jury, because I have huge concerns about that, particularly with regard to the maternal antiphospholipid syndrome and the possibility of the babies being affected by that, and how that was kind of concealed to the jury. But also the issues with the SLE, which I'm still, it looks pretty certain that the mother did have lupus, which, if you add that to antiphospholipid syndrome, massively increases the risk to that pregnancy. So that case alone would more than justify my and any medic's view about the importance of looking at the maternal and obstetric history. And I think once those notes it's inconceivable with a mother in her 20s who'd had a stroke before this index pregnancy. There must have been an absolute myriad of documents, communications between her GP and the local hospital and the experts in London that had repeatedly seen her, which will give every single bit of medical obstetric bit of information that anyone would need to answer any of the questions that we have, but very little, if any, of that got out. So then baby C, again, an incredible case. This was a preterm baby. This was a baby that was severely growth restricted. So again, for the non-medics, that basically means that it was picked up quite early on in the pregnancy, and normally it's on the ground, on clinical ground. So the mother it's the classical situation where it's, oh, you look very small. And at some point in time, the mum gets referred in for an ultrasound scan, and it proves that the baby's sort of fallen off its growth centiles. And the only effective clinical way of doing that is through serial ultrasound scans. So this baby was minute, and to put that in perspective, the baby was about half the weight at delivery that it should have been. So its birth weight was only 780 grams. So this is a baby that would literally fit in the palm of one hand. So this baby was in severe trouble, and from details that Jim McCormack, the obstetrician fetal medicine consultant from the Cancer Chester, relayed to the Thirlwall inquiry, you can get an idea of just how concerned he was as the managing obstetric consultant about this baby's condition. He picked up that the placental function of this baby was abnormal from 18 weeks. 18 weeks. So, that's incredible. That's even.
Can I just ask you, because I don't have any knowledge of the contextual significance of this. So, how early is 18 weeks? What's the importance of that?
Well, if you think term for a pregnancy, Chris, most people think term is 40 weeks for a human pregnancy. It actually isn't. The proper definition of term for a human pregnancy is any time after 37 weeks. If you put that in context, there are two critical gestations. One of them is the gestation at which we view viability, and that legally now is at 24 weeks. Now, there are cases of babies that have survived gestations lower than that, but that's pretty exceptional. What's even more exceptional in the small number of babies that survive if they're born before 24 weeks is the likelihood of them surviving intact and with a good quality of life. So that's one gestation that's critical. So, and if you look at the other gestation that's critical is when babies get the most detailed scan in the pregnancy, which is specifically scheduled normally between 18 and 21 weeks of the pregnancy, when you can, and that was part of the job I did, you do fetal medicine scanning, so every pregnant lady is offered a detailed scan of the baby at that gestation to check if there are any major structural problems in how the baby's made up, and you're looking them for life incompatible abnormalities. But you're also looking for, presumably, what was picked up with this baby. You're looking for, very occasionally, you'll find only halfway through the pregnancy, you will find that babies are much, much smaller than they're expected to be. And we're in a much stronger position now to diagnose these pregnancies because 99% of mums receive an ultrasound scan in the first trimester of the pregnancy. So it confirms they're pregnant, it confirms the baby's alive and they haven't miscarried. It very, very accurately dates the pregnancy. So once that scan at 11, 12 weeks is completed, you can then within a day or two, nail the due date. It allows you, on the basis of that, for every scan the mum has from that, you can very conclusively tell whether the baby's meeting its growth potential. And it allows you to detect how many babies they've got. So all of those are fundamental. So this baby was, so I'm assuming this baby was scanned at 18 weeks and they found that the placental function was abnormal. So I'm assuming from that, and again, I haven't seen the notes, I haven't had access to the scan reports or any of the maternity notes, but you would infer from that as an obstetrician that the baby was very small even then. So then you're going to worry about, is this baby genetically normal, or is it a pure placental problem, or is it both? So babies that have got, for instance, Down syndrome or Edwards syndrome or other of the most common, sometimes less common genetic syndromes will present sometimes with smaller babies. Or is it just that the placenta, so the critical link between any mother and their baby, is not functioning properly? So the baby isn't getting enough goodies, enough nutrition, enough oxygen from the mum's circulation to thrive. So the baby's placental function was found at 18 weeks, so halfway through the pregnancy, to be abnormal. And this is where it gets a bit complicated. The baby was found to have what's called reversed end diastolic flow, or in some of the documents it's noted as REDF. Now, I'll try to explain this. The the baby's link with the placenta is like a plumbing system. So if you buy an old house and all the boilers are and all the radiators are furred up with gunk, the baby's heart, which is equivalent to the pump in the boiler, will struggle to pump the hot water around the radiators. So you never get warm radiators and you never get a warm house. But normally the blood flow is always, or the hot water in the boiler analogy, is always moving away from the boiler towards the radiators. So that's the equivalent of the baby's heart pumping the blood back to the placenta, to where it gets oxygenated. So the normal situation with a baby is throughout the pumping phase of the heart and the relaxation part of the heart where it's not pumping, the blood is always flowing away from the baby towards the placenta. That's what you want to have. So if a baby's getting into trouble because if you like, the radiator is furred up or the placenta isn't functioning well, then the first thing you often see on the ultrasound is you get what's called absent end diastolic flow. So rather than when they're in the pumping phase, the systolic phase of the heart contraction, the blood moves away from the baby, but then it stops, but it doesn't do anything else. The most extreme version of this is what baby C had, which was reversed end diastolic flow. So that is where the heart pumps. Then when the heart isn't pumping, there's a pressure problem upstream in the placenta. So the blood flow is then reverted back towards the baby. And that's a real problem. And as soon as that is detected, pretty much you need to be planning that baby's delivery, because if you don't, you're going to get into real trouble. And then there are other Doppler studies looking at the blood flow in the baby's brain that you can use as well, because nature's quite clever, and if a baby's getting into trouble, there are hemodynamics, so blood flow modifications that nature undertakes, which says, well, I'm getting into trouble, I'm going to divert blood away from the bits that I don't need to survive, and by that I mean the muscles of the baby and the other organs, and it diverts the blood supply to the brain. And you can actually pick that up very cleverly with ultrasound. So that's another warning sign, which I'm sure this baby would have had. So that's complex, but this baby had that. So, Jim McCormack making the decision of monitoring, he would have scanned this baby probably umpteen times, and he would have been looking for these signs. Added on to that, probably he'd have been looking for CTG, so baby's heart rate changes as well. And it's normally a combination of seeing reversed end diastolic flow plus CTG problems. Almost invariably in these babies, the mum will report the baby stops moving, because if this what's called redistribution of blood flow occurs, diverting blood away from the muscles to the brain, then the baby just stops moving. So normally it's a combination of all of this that will say enough is enough, we need to get this baby out. But from the evidence that McCormack gave to the Thirlwall inquiry, he painted a picture of being very, very concerned about this, and I'm not surprised. To have abnormal placental function at 18 weeks, reversed end diastolic flow, delivering prematurely. He didn't really pull any punches about this baby in Thirlwall, and indicated that he thought it was very likely this baby wouldn't survive antenatally. But of course, again, it's a smoking gun thing, isn't it? He had a baby who was very vulnerable. The other consequence to the baby of all this blood flow thing is they commonly get other organ damage as a consequence of that. And I suspect with this baby, it probably had, because you often pick up what's called ischemic bowel in these babies. So the baby's bowel on antenatal ultrasound looks bright white. What's called hyperechogenic bowel, it sort of shines on the ultrasound. And that's often because the blood supply to the baby's bowel has been adversely affected. And then that links postnatally. And again, this should have all been fed back to the neonatologist, was it? That feeds back to things like necrotizing enterocolitis, which has been mentioned in many of these babies, and potential gastrointestinal bleeding. So, Jim McCormack clearly appropriately recognised that this baby was in significant risk and danger, and he seemed very unsurprised that this baby didn't do well and didn't survive. But were the parents warned of that? One would hope so during the antenatal course. But then, of course, Dowie Evans comes in and said, "Oh no, all of that's irrelevant. This is what killed that baby." And then there's even more information, and then it appears that once baby C was delivered, the placenta was sent off for histological examination, and it appears that there was some sort of placental pathology. Now, was that just specific for this baby, or is it relevant to other pregnancies for that lady? I don't know, but I sincerely hope that was investigated and the potential implications of that were given. So that's another example. Baby D we've covered. Failure to recognise and manage the importance of preterm ruptured membranes and failure to give antibiotics appropriately. Nobody anywhere can argue that wasn't negligent mismanagement of that case. The other case that springs to mind is the triplets. And I've gone on record of saying that I don't know what caused the subcapsular hematomas, but it would be very, very easy to tell and to prove whether the theory of a traumatic, difficult delivery was the case. And it'd be very easy to rule that out if the delivery was entirely straightforward from the obstetric perspective, and the babies were handed over to the neonatologist in good shape. And we just don't know. We just don't know. Mm. So I think that's just 4 of the cases, and it'd be very easy, I'm sure, to pick holes in several, if not all, of the other cases, given time and given access to the maternity records.
Yeah, I mean, we'll certainly be doing that in the future as well. We're going to look at some of the other cases, no doubt. But I think that was a very thorough answer, so that's great. So we have questions now across multiple kind of sections that we've identified. So what I will do is I'll just go through and ask you 1 or 2 from each section until we reach the end of the interview. Because
just in case I forget later, the critical importance of my stance on this is that it appears I'm not a barrister, I'm not a lawyer, I've got no legal qualifications, but it appears to me that one of the fundamental issues about where this goes now, does it get through the CCRC, does it get referred up, is about whether any new evidence is available that is presented. Now, from my perspective, the vast majority of what I've disclosed to you, given my level of clinical experience, appears to be new evidence that wasn't presented. And that's, and this is why I hope Mark MacDonald has gone along the lines of what I suggested ages ago of getting Jim Thornton and now an obstetric panel to look at the notes, because by definition this is new evidence that wasn't presented that could have dramatically changed the interpretation of these cases, if not torpedoed Dowie Evans's ridiculous theories. So sorry, I just want to get that in case I forgot later.
No, that's absolutely great. That's great. Very good point. So I have these sections. So what I will do is I will ask 1 or 2 questions from each section until we run out of time, and then we will return to the remainder in future interviews, future videos. So I'll begin by asking, what is the usual chain of command and organizational structure around maternity, obstetrics, paediatrics, and neonatology?
Okay. It doesn't really differ from other medical specialties, and it is to a degree hierarchical. But I say that having had the experience of seeing medicine when I first qualified, where it was poles apart from where it is now. I mean, I qualified, and my initial jobs were in the sort of the old style, where the consultants were literally godlike, and all the other members of the nursing, midwifery, and medical team, when the consultant walked on the wall, almost sort of James Robertson Justice levels of fear, if you like. And the consultants were never challenged; they dictated what happened, and woe betide you if you didn't adhere to their requirements. And that, praise the Lord, died out years ago. So there is still the only way medicine can work is if you have some kind of ultimate responsibility for clinical decision making and accountability. So that side of things hasn't changed, and that's why you're called, as I was, a consultant, and that's why, if you like, you kind of sit at the top of the medical tree. So the buck has to stop somewhere. So from the medical perspective, if you look at that hierarchical tree medically, then and neonatology is no different from obstetrics, and that in the UK certainly you don't you don't do your first post-qualifying job in one of those specialties. So when you qualify as a doctor, you do your what are called foundation years now in the more sort of generalist specialty. So on the whole, you do a medical job and a surgical job. You then tend to decide whether or not you want to subspecialize. So the first tier of medical grade in obstetrics and neonatology are called the foundation jobs. When I went through, they were called SHOs, senior house officers. And you tend to work on a rotation, normally within a region now, and you do normally 6 months, sometimes longer jobs in that specialty that can go up to a total of about 2 years normally. So I did 4 6 months jobs in different hospitals. You then become the next tier up, which is called, and they've just changed the terminology now for, rather than junior doctors, they're now called resident doctors. And the next tier at that level is the specialist registrar. So you then decide that career is for you, as I did, and you then get appointed to a specialist registrar rotation, where you basically learn the tools of your trade. It's normally about 3 years or so as a registrar. And you sort of progress through different jobs, normally 1 year in one hospital working in different specialties, and then you gradually become more specialized, going up through the ranks of specialist training up to the higher levels of 6 and 7. Some people do research, some people do other more specialist like fetal medicine subspec training, so they do more years. You then complete your specialist training requirements, and you get a certificate, which is basically saying, yep, you've ticked all the boxes, you've done everything you need to, you can now apply for consultant post. And then it's a matter of finding a job that's applicable to you, applying for it, being interviewed, and then hopefully being appointed. So that's how it works. So in any department, if we concentrate on a neonatal unit, as most of this refers to, then that will be manned by resident doctors. So most, and this is 24/7, 365 days a year. It always used to really rile me that, particularly around Christmas and New Year, which is obviously topical now, you can't run an acute medical specialty if you can't provide a safe level of service 24/7, 365 days a year. And it used to really hack me off when you could see that the standards of care were not adequate or optimal because it was Christmas Day. Now, nature doesn't recognize bank holidays. It doesn't recognize Christmas. It doesn't recognize New Year. So you've got to provide a service that provides safe and effective evidence-based care and safe care to your patients 24/7, 365 days a year. So that care is provided normally by resident doctors. So in a neonatal unit, you'll normally have senior house officers or foundation doctors in the first couple of years of their specialist training, plus or minus more senior doctors at the registrar level. But you will always, every single moment, have a nominated consultant responsible for the patients. Now, I can tell you with certainty at the Countess of Chester, which was similar size to the hospital I worked in, the consultants were not resident on call. So they out of hours, so they would do their normal working shift, and then at 5, 6 o'clock, the other consultants would go home and they would work on a rota, as I did, where between 5 o'clock in the evening and 8 o'clock, 9 o'clock the following morning, you were it. So you were the consultant that was responsible for the service. And at the Countess of Chester, it's quite clear that they were principally paediatric consultants, but they cross-covered the neonatal unit. So out of hours and at the weekends, they were responsible for what was going on in the unit. So out of hours, but that hierarchical structure of responsibility is the same in working hours as outside of working hours. You have the junior doctors on the wards, and you have consultants on the wards. But the attendance, the involvement, the responsibility, the accountability of those different senior tiers clearly varies both individually, according to the aptitude and professionalism of that consultant, and sometimes differs between units. And certainly nowadays, bigger units, teaching hospital units, certainly at Liverpool, the consultants will be resident on call. So they will have realised that it's too busy, it's too technically challenging, and you have to have a consultant present 24/7 on the unit with immediate availability. And that appears to be a very significant issue at the Countess of Chester in that there are significant questions, particularly it was relevant to triplet O. How available were the senior doctors? How long did it take the registrar to get back when that baby crashed? Most importantly, critically importantly, how long did it take during working hours on a normal day, working day, for a consultant to be available? If a baby crashes, you want a consultant to be present within 5 minutes, not 45 minutes, which I think is what it took with baby A for a consultant to pitch up.
Why would it take so long?
I've got no idea. I don't think that was established. Where was you can understand it from my perspective as a consultant when I was working, Chris. If I live about 4.5 miles away from the hospital, you have to. One of the basic requirements of your job when you're on call is you have to be available and to be able to get into the unit clinically within half an hour, 24/7. That's out of hours. That could be 3 o'clock in the morning, which in our specialty wasn't that uncommon. So how it can possibly take over 40 minutes during a normal working day for a consultant to be fast bleed to a neonatal unit, it's unacceptable. It doesn't appear to me that much of an issue was made about that in the case, and that's again going back to the fact that there wasn't a defence neonatal expert who I would have hoped would have raised that as an issue. So that hierarchical structure applies across most medical specialties, and it's not that dissimilar to nurses and midwives in that you have the student midwives, you have the junior midwives, and then it works up in midwives and nurses, it works up a number grading according to seniority and responsibility. And then sat over the top of that, you have a managerial structure, and which is where I came a cropper because I dared to challenge the clinical managers in my department who were senior midwives about patient safety issues. And then they obviously fed up to what are called the execs, so the members of the trust board, who are the non-clinical senior managers. So they kind of run the hospital and tell you what you can and can't do, really. And then in between you have normally consultants that have decided to partly or totally go into managerial roles. So you have things like clinical directors, and then divisional directors, and then a medical director who is normally a senior doctor who has decided to commonly completely go into management, sometimes partially, but then they oversee all of the medical staff of the hospital. So they're either called medical directors, or in the trust I worked in, they were called chief medical officers. So that is the basic hierarchy of what happens, and it normally works pretty well. But you have to have somebody who, at the top of the tree, and certainly in my specialty, in my career, the consultant, and you have to have somebody who makes the decisions and takes responsibility for those decisions. It cannot work, and that's part of the problem that's going on with the maternity crises around the country now. Is that there is in some units a lack of clarity about who is making the decisions, and silo working where there's not a great interrelationship between the different specialties, and that can be very dangerous. So I hope that
yeah, absolutely. So I'll ask a kind of follow-up or related question. So I promised that I would say, please give Dr. Pitman my best. It is so clear to see he's a dedicated physician. So this question is from Jenny, who I've interviewed, who's making her own videos now as well. So the question is, when Dr. Pitman knew he had a high-risk pregnancy and delivery was approaching, how would he notify the neonatal team and what would he have discussed with them? Also, would the neonatal team then have a discussion with the parents as to what to expect once their child was delivered?
Great question. My stance on that is that the earlier you know, I mean, the reason I hesitated, I was thinking about a case that I could use as an example, and the classic one here is the twins A and B. A very complex pregnancy, lots of medical issues, treatment issues, almost an inevitability that those babies were going to come early, high risk of complications like preeclampsia and blood pressure problems. So my stance on this is you're very, very unlikely to be criticised for telling the neonate too early about a case. So my stance was when I met a mother or a couple that were embarking on a, like twins A and B, a high risk pregnancy, or the other case, classic case being the natural triplets, OP and Q. Pretty much as soon as I seen that lady in my antenatal clinic for the initial referral, once you've got past the gestation of likely miscarriage, so by then I'm talking sort of 12, 14 weeks, once you've overcome that, so if you're going to lose a pregnancy through miscarriage, it's far, far less likely after that gestation. I would then be formally writing to my neonatal colleagues to say, and the great benefit you have is because of these, what I discussed half an hour ago about these early scans, you can be absolutely certain when somebody's due dated. So that's based on that first scan. So you can then say with the triplets, for instance, I would have said, well, look, we know that we've done really well with this pregnancy if we got to 34 weeks. So I would then say that, can you put in your diary in the neonatal unit that if this pregnancy progresses in an uncomplicated fashion, can you put in the diary that at or about 34 weeks, we will be delivering this lady, Mrs. Smith, because you need to give the neonatal unit adequate warning that they need to have 3 cots available, they need to have a shed load of staff, and they need to have enough paediatricians available, senior paediatricians available to potentially take, God forbid, but 3 potentially compromised babies. And that's a challenge for even a massive teaching hospital. But for a unit of our size at Winchester and the Countess of Chester, even more so. And the big question with the Countess of Chester is, were they adequately staffed, trained and able to take complex babies at that gestation with that degree of complication? And I would suggest the answer to that was no. So that's the first answer to Jenny. The earlier the better. And then, of course, moving on from that is there would then be regular follow-up. So our neonatal unit would have a file of expected cases. And, whenever I wouldn't, at every antenatal contact with a complex patient, I wouldn't update the neonatologist, but I certainly would if there was anything that, if the lady developed preeclampsia, so you're looking at maybe delivering the triplets earlier, I would let the neonatal unit know. Anything that came up that made me think, oh, this is now getting even more complex, I need to let the neonates know. You're not going to be criticised for, bombarding them with paperwork. But the worst scenario, which seems to me to have been a regular occurrence at the Countess of Chester, is where you're so siloed in your working practice. So you have the obstetricians, you have the neonates, and never the twain shall meet. And there was ample evidence, having spent some time looking through the Thurwell documents when they interviewed nurses, where there was grave concern raised by numerous nurses about the lack of transfer of critically important clinical information between the 2 parties. So that raises very dramatic questions about, well, why weren't the obstetricians telling the neonatologists what they needed to know? And that certainly appears to be the case with the twins A and B. And then, when you then make a decision, so, if you decided to deliver the triplets at 34 weeks, once that decision had been made, when you plan to bring the lady in for steroids and you were planning the delivery date, then I would have probably gone down to the neonatal unit, notified.
Just come.
So when you're making the final decision about delivery, then absolutely you would then you would tell the, going back to the triplets, you would tell the neonatologist, okay, we're delivering on Friday, coming in for steroids on Thursday, and that would then enable them to check on cot availability and to sort the staffing out. And you'd also tell the anaesthetist if you're having a cesarean section. So
Yeah.
yeah, so it's a critical part of your job as a senior obstetrician to tell the worst possible thing for the neonatologist is for them to be dumped classically out of hours with premature, complicated babies that they knew nothing about. That was the one way to really rile and understandably rile the neonatologists if you were massively increasing their workload without them being prepared.
Good. I like it.
And a fundamental part of that, sure, of course, you have to tell the parents. As the obstetrician, you have to, every single decision you make, every debate you have, most clinical decisions are a choice. And they have fundamental effects on the babies and those parents. So you have to discuss them, consent them, and discuss the alternatives. So absolutely, it's a fundamental part of your role as any senior clinician. Absolutely, to prepare them for the worst. And more often than not, I think in life, if you're prepared, if you're expecting the worst, then you normally end up pleasantly surprised. So there's a huge amount of importance in the preparation for complications.
Good, well, that's great. I'm going to ask you a question now about child A and child B that we've discussed previously. So with regard to these infants, now that we know they completely ignored the mother's obstetric history, as an obstetrician, if that was your patient and you found out they ignored all your hard work and effort, how would you feel, and what steps would you have taken in order to ensure that this would not happen again?
So is this me as an obstetrician or me as a parent?
Yeah, well, I think both of those would be interesting, but I think it's more from a professional perspective. You know, you're the obstetrician.
Yeah.
If you're ignored, you know,
I've this is probably one of my biggest problems with what I think was going on in that unit and how I would have acted differently, Chris. You dedicate an enormous amount of your time and expertise and sometimes stress levels into optimizing your management of complex pregnancies, and that was my bread and butter. That's what I trained for, and that's what I think I was half decent good at. If I was working in a unit where despite my best effort, so I did everything that the vast majority of one's professional peers would have said, oh, Pitman did a pretty good job with that, couldn't have done any more, he might have made decisions that I wouldn't have done, but I can see why he made that decision. So, good on him. He did everything in his ability to optimize the safety and management of that pregnancy. If despite that you were recurrently getting adverse outcomes, which appears to have been what happened at Chester, I couldn't have let that drop. I would have, principally from the parental perspective, because it's not as simple as just seeing a clinical case and making a decision. You build up in many cases, sometimes a lifelong relationship and friendship with parents. And I'm still in contact now with parents I've looked after throughout my career. Still get Christmas cards from some parents. So there's that side of it, but there's also the professional responsibility to what you're doing clinically and to the baby. And if parents that I looked after and babies I looked after that were having catastrophic outcomes despite my best efforts, then I would have been jumping up and down. And I don't know, did that happen at the Countess of Chester? I'm not sure. I don't know. So that from a professional perspective, I would have found that, and you have to question the amount of obstetric input that happened in the debriefs about these cases. I think the last session we did when we looked at Baby O, we looked at the released hot debrief that one of the consultants involved with that case, and it's quite startling that there seems, my perspective, my opinion, there seems to be a deflection from the obvious about the needle insertion and where it was and could that have caused an injury. It's mentioned, but then it's deflected onto almost elements of praise for other bits of completely irrelevant management, and other criticisms with that case about, well, antibiotics were given, they needn't have TPN. So was there senior consultant obstetric input when in the dissection of these cases, which must have happened, I assume? So that's where I would have been. I'm thankful I never faced that. I mean, our neonatologists at Winchester were exemplary. I had a fantastic relationship with them, and I hope they, even now would view that, the same retrospectively with regard to my clinical input. From a parental aspect, it's quite hard to answer that, because of course the parents in real time don't know, and of course if you're not medical, then you wouldn't realise what should and shouldn't happen. The only thing that contradicts that, of course, is the accounts of, again, the triplets' parents, who gave very graphic descriptions of horrendous stuff that they reported. Scenes of pandemonium, I think, was of panic when there were problems with their babies, and then the classic thing of somebody looking up on Google about how to insert a chest. I mean, just imagine that as a parent. You've lost one baby, and then there's problems with another one of your triplets, and you walk onto the unit and you find junior doctors looking up a clinical procedure on Google on the computer. I mean, it's just astonishing. But as the average parent, not being exposed to that, when you aren't going to perhaps realise what should and shouldn't happen, then I think it's very, very difficult. And what you're asking is, would you move your care of for me, it would be spouse, to another hospital? Well, it happens, but it's not. You understandably have a degree of trust, respect in the professionals that have got the responsibility to care for you and care for your child. So it's a hell of a call to challenge that and to move your care elsewhere. Probably it's got a bit easier now with Martha's rule, of course, because this thing's now brought in where any patient, I was out of my job by the time this came in, but now, of course, any patient, and in maternity it would be parent, has the legal right to request a second opinion. So I guess you could do that, but I don't know how that would have worked at the Countess of Chester. So I think, I would have had huge problems if I was a consultant obstetrician at Chester seeing this unfold, and I can't believe that I would have really struggled, having built that relationship up with the parents and safeguarded to the best of my clinical ability those babies, to then find that number of babies were suffering potentially avoidable adverse outcomes. Particularly when you take on board, there's a lot of stuff going on social media about the infection risk to these babies and the sewage and leaking through the roof. Presumably the obstetricians and the neonatologists must have realised this. And again, I was thinking what I would have done at Winchester had we have had sewage leaking through the roof and being dependent on nappies around pipes in the roof to stop, and not being able to utilise sinks in the neonatal unit. I mean, I don't. It wouldn't have happened, and had it have happened, as Hugh Lee would have said, the department would have been closed down, and the hospital would have been closed down. So many unanswered questions.
It feels to me, as an outsider, that the sewage issue obviously has had a significant impact, with sepsis and so forth. But I don't know. To me, it shouldn't have been that hard to deal with. Yes, they definitely should have shut the unit down, but surely that you'd be able to resolve it fairly quickly. Would you not think? Is that a reasonable assumption?
You'd need to consult the defence's sole expert, wouldn't you, with the plumber to answer that. I mean, often the unit we worked in was dated back to the 70s, and it was a bit archaic, but we never had anything like that. And we had there were sometimes baths would overflow, and my office was flooded once by I think it was a tap that was left running in a sink, and it came dripping, and my office was on the ground floor. But, yes, that's addressed, and so, but that's a whole different ball game from raw pseudomonas containing sewage leaking into a neonatal unit. And there's another case that's come to light today on social media that I wasn't aware of, and there's a baby that was in the same room as twins A and B, and parents that have been roundly praising the care that their baby received at Chester. It had to be transferred, I think, to Liverpool. But that was a 34, 35-week baby that was born in good nick. And then guess what? Had quite profound infective and septic morbidity, including a series of skin abscesses. And you say, oh, whoa, hold on. And then, did okay and survived. But that baby was in the same bay as twins A and B. Wow. So then that's another case of concerns of infection and sepsis about a premature baby that was in that unit but survived. Huge issues. Huge issues.
I mean, basically, the reason I say it's simple is that basically there's only two things you can possibly do. You either replace the entire plumbing system and just knock the pipes out and replace them, or you just close the unit down completely. And ultimately, they did the latter because they obviously demolishing the unit and they moved out and they've got a new neonatal unit. But there isn't you can't sticking plaster that issue, can you? You've got to either say to a plumber or estates person, right, we need to replace the plumbing in this unit, or you need to replace the unit itself. There is no other reason.
No, it is, and I don't think you find any clinician or particularly microbiologist that would argue anything differently. And then when you add to that, I can't remember which set of parents it was. It may have been the triplets again, who stated that there appeared to be a distinct lack of hand hygiene in that neonatal unit. But then they recognised it, but then it was emphasised even more when their third baby was transferred to Liverpool, and they said it was like chalk and cheese. It was the standard of care there and the hygiene aspects and the importance of hand hygiene and using washing your hands and then using gel and taking your watch off and all that sort of stuff. From their account, it was complete. The poles apart. Well, that's terrible.
It does seem awful because even when I've visited hospitals, it's a bit of a pain, isn't it? But you just think, well, I can't bring germs in. That'll be awful.
And I think COVID made us far more aware of that sort of thing. I think the whole COVID mask thing was probably overly played. But I think the positive thing about it was the hand hygiene. If you're coughing and spluttering into your hands, then what you need to do then is wash your hands. And that's just for the members of the public, not clinicians that are moving between patients, particularly when you're dealing with without any doubt, immunocompromised medical patients, which neonates are, because they haven't had the opportunity to develop their own immunity. So you need to be even more obsessional about it. And that doesn't appear to have been the case.
Yeah, absolutely. So I'm going to ask you a question now, a general question about multiple infants. And this question goes, since many of Lucy's babies were multiples, how does obstetric care for a multiple differ from that of a singleton? And what would be Martyn's greatest concerns for a baby of this nature in the first hour or two after birth?
That's a complex question. So I'll simplify as much as I can. And I specialised in the management of multiple pregnancies as part of my role, and that obviously included twins and triplets. And we had probably one set of triplets every 2 or 3 years at Winchester. Most units, and this has come through accepted national guidelines from a few years ago now, they came out and stipulated that multiple pregnancies were high risk. I don't think anybody disputed that, but said on the basis of that units, if you're going to look after multiple pregnancies, particularly the more complex ones, the monochorionic ones and the higher order multiples, triplets and more, that you needed to set up a dedicated twin antenatal clinic. So that would involve normally a fetal medicine consultant, maybe another obstetrician to cover their leave, and commonly a dedicated multiple pregnancy midwife. And to have the availability of the free availability of significantly qualified and expertise sonographers to do the ultrasound scans to monitor growth, and to have either on site or in smaller hospitals like we were, a very close working relationship with a tertiary unit. For us, it was Southampton, where the complex pregnancies, if you were getting into trouble with monochorionicity and twin-to-twin transfusion, which we discussed in relation to the triplets, you had a quick and effective referral system down to them so that you could get their input and for decisions regarding treatment. So again, to simplify things for the non-medical people, the reason twins are, mums who are carrying twins are basically at greater risk of just about every single pregnancy complication you can imagine. You're more likely to miscarry, you're more likely to go into premature labour, you're more likely to deliver early, you're more likely to get bleeding, you're far more likely to get preeclampsia and hypertensive problems, you're more likely to have to require an induction, you're more likely to require a caesarean section, you're more likely to have difficulties in labour because the womb is significantly distended, therefore it doesn't contract well. If you're aiming for a vaginal delivery, there can be complications because it's a pretty low risk strategy being the first twin, but the womb tends to stop working after the first one has come out, and you can then get into problems with the second twin. More likely to require a caesarean section, both electively and in an emergency. In my experience, when I used to look at outcomes with twins in our own unit, and it was almost invariably, if you got into trouble with attempting to deliver twins vaginally, almost invariably it was out of hours. So I always used to, if I was on call and there were twins delivering vaginally, I would always go into the unit for the delivery, because it was too late. If I got a call at 2 o'clock in the morning, oh, Dr. Smith can't get the second twin out, can you come in? By the time I got into the hospital, it would probably be too late. So I would always go in for the delivery. Yeah, more likely to have caesarean sections, more likely to bleed afterwards. So they're complex pregnancies and they're difficult decisions. One of the simplest things to explain is a lot of the relevant clinical information for a single baby is gained from measuring the baby clinically using a tape measure. That is completely useless for a twin pregnancy, because you can't, if you're just measuring the height of what's called the symphysia fundal height. So it's using the technologically advanced bit of kit that is a tape measure, which is used in most singleton pregnancies to measure to judge the size of a single baby from measuring the size of the uterus. Completely useless in twins. So so you're entirely dependent on scanning, and hopefully both babies will grow the same, but sometimes you get a big baby and a smaller baby. And in that situation, particularly if they're sharing a placenta, it's when do you make the decision to deliver? Because you don't want to deliver at a gestation if one of the babies is doing well and one isn't, when you potentially jeopardize the well-grown baby to salvage the smaller baby. So complex, and I found it challenging and very satisfying decision processes, but yeah, very complex pregnancies, and not to be taken on in a light-hearted fashion, and definitely benefited as far as quality of outcome from the setting up of established high-risk clinics specifically aimed for their management. So
yeah, very interesting. So I've got quite a few questions about yourself, and we've discussed the issues that you've experienced in the NHS previously. So one that I would like to ask is the following. So it says, I'd like to ask Dr. Pitman, is he completely banned from employment within the NHS? Are there alternative career paths he could pursue where he could use his undoubted skills, knowledge, and experience? It seems such a terrible waste of an outstanding doctor.
that's very kind and very flattering. So the answer is that there was no ban put on my practice, despite what's being pushed around on social media. And on that subject, just going a little bit lateral on this, I always think that whenever you put a post on social media, whenever we do one of these interviews, Chris, I always think it's very, very gratifying if the response to that is a wave of insults from trolls, and particularly ad hominem attacks. So they choose not to challenge what you said clinically, because obviously they can't, but to just go for things like, oh, he lost his employment tribunal because of this, most of which is factually incorrect anyway. So I lost my job and was unceremoniously dismissed from the role that I believe I conducted with a high degree of success over 2 decades, on the basis of what in employment terms was justified through what's called some other substantive reason, some other substantial reason, sorry. And the justification for that was that it was deemed by the small number of in fact, 5 senior clinical managers in the trust and non-clinical managers, that my working relationship with them had become untenable. So they ignored I estimated about 400 other people that I worked with on a daily basis, who had not expressed any dissatisfaction over the entire period of my clinical tenure as a consultant, or indeed through my other 10, 12 years as a junior, that there was any problem with working with me. And despite 30 years of exemplary appraisals and 2 absolutely top drawer GMC revalidations, that was all ignored. No mention in any of those of interprofessional problems or bullying, which is the other common accusation that's thrown my way. So it was a very, very small group of people who had a vested interest in shutting down my concerns about patient safety, all of which, I hasten to add, were later proven by CQC some 2.5 years after I initially raised them. So that was what happened. There was no dispute, again, contrary to what's banded around on social media, there was no dispute in my employment tribunal that I was a whistleblower. That wasn't in there in black and white. Mr. Pitman did whistleblow legitimate concerns about patient safety in his organisation. The reason I lost my case is that, inexplicably, despite there being ample and adequate evidence to back it up, the judge decided that there was no evidence that the detriments that I experienced, so basically being victimised and pushed out and gaslit for my career, there was no evidence at all in his eyes that was a consequence of my whistleblowing, which was just completely and utterly bizarre, really. So I wasn't referred to the GMC because there was no grounds to do it. I was repeatedly told by the chief executive until latterly that it wasn't about my clinical standards, and my clinical standards, surprise, surprise, are exemplary. So I wasn't referred to the GMC. So my license wasn't taken away. But the reality is, if you look at the natural history of what happens to NHS whistleblowers, it doesn't actually matter what happens. Obviously, if you win your case and you get a massive settlement, which is, if there was any justice in this world, is what should have happened in my case, then it becomes less of an issue. But if you lose your case, and if you get labelled as a whistleblower, then you're finished clinically. And there's ample evidence and natural history of that to support that. So from the moment the judgment came through, I realised within hours, really, that was it. That I'd not only lost the job that I loved doing in the hospital I love working at, but I'd lost my cherished career, I'd lost my income, and I'd lost any possibility in getting another role. The reason for that is, even if I'd applied for other jobs, then obviously the units that are applying for a consultant obstetrician, my clinical standards, my level of expertise, my level of experience, which as an obstetrician labelled, particularly in the current climate, and as a fetal medicine trained sonographer, would be incredibly valuable to a unit. They would do their due diligence, and they would think, hold on a second, this guy's 60 now, or nearly. What's all this about? So I'd have been 58 if I'd have applied immediately after I'd finished my employment tribunal, and they would have phoned around, and it wouldn't have been difficult for them to speak to, and they'd have phoned around the very people that were put themselves up in the employment tribunal against me, and they would have received information that would have made their decision. And most NHS trusts in this situation with a whistleblower would say, oh God, this guy does it pretty good on paper, and his GMC revalidations are exemplary, and he's never been in any trouble with the GMC, and he's got skills and qualities that we really need, but we can't afford the risk. I mean, what's to say, you get in here for 18 months, and then what's to say you wouldn't do the same here? So you're finished. And there's another example of that. My case couldn't have been better publicised. It was in the local press, in the national press. It was everywhere. And latterly on social media, and which has been said, why doesn't he just get another job in another unit? That even was brought up by Ed Balls when I was interviewed on GMTV. The other issue is it's not exactly difficult to get hold of people now, is it? To phone them up or contact them through social media to say, can you come and do a job here? Your phone doesn't ring. So, and the other thing is the without going into details for obvious reasons, the psychological consequences and damage of when you've been through over years what I was put through for what exactly would make it, I think, almost impossible to embark on another job. And if I did, I would be forced to practice so defensively that would be no good at all to anybody. And you have to, I think, when you've been through what I've been through, you have to act to a certain degree with self-preservation, really. And I'm not prepared to put myself potentially in that position again, because you can imagine in a high-risk, high-stress specialty like obstetrics, you're bound to have, as a consultant, clinical disagreements with people. And it would be so easy for me to come unstuck in a future job, difference of opinion at midnight on a Friday night with a couple of senior midwives, and I make a decision and decide on the basis of being the consultant that this is what I think should happen. And then those midwives, and there's a very, very faint line, as I found, between being assertive about something and being accused of bullying, particularly when there's a gender difference between the person making the decision and the people on the other side. So it became pretty obvious, regrettably, that my time was done. But I got an enormous amount to be grateful about. I mean, I had 3 decades of exemplary, I think, medical practice, and the amount of positivity and support that I got from thousands of patients, and still do, was incredibly gratifying. And it's not that long ago I wouldn't even be able to have this sort of discussion with anybody. So I'm clearly in a better and stronger position healing wise than I was not that long ago. So yeah, it's a painful, and this isn't unique to me. I'm in contact with so many other people across all sorts of different careers, but particularly medicine, and particularly the NHS. And try and think positively about things. And I guess the only positive thing about me was my age when it happened. I wasn't 38. I wasn't 45. I'd seen out most of my career, so it was financially catastrophic what happened to me, and it certainly hasn't left me with the retirement that I'd planned and wished for, but it could have been worse. And that's partly why I'm doing this, because what happened to me was nothing like what happened to Lucy Letby. It's not even in the same ballpark, but there are a lot of similarities about her brush with the legal system and what happened to me. And it's not about, there was nothing in my employment tribunal about establishing the truth, nothing at all. It was about securing or preventing an individual getting the appropriate response against the monolithic structure that is the NHS. That was what my case was all about. They couldn't afford to make the appropriate decision, and I think with Lucy Letby it was very similar. They wanted to nail somebody.
Yeah, absolutely. So the other side of that question is that, so this person describes as an alternative career path. I guess you could say, is there a related profession or related job that you could do where you could use your skills and experience?
I guess there's always alternatives on there, but I guess it's also down to, I was thinking the other day actually about, had this have happened to me at a younger age, I'd have been forced to do something different. I don't think it would have altered my view on getting back into the same job again, because I think the same stresses and psychological challenges and fear of it happening again would have existed. The medical legal side of things has always fascinated me, and I guess that's partly explains and justifies what I've been doing with my opinion on the Lucy Letby case. So I may have gone into that. I could see some possibility about maybe had I been younger to have gone into maybe becoming a coroner or something like that. Um, I got interest in. A lot of people ask me, why don't you use the skills that you've got to investigate other units and things like that. There are possibilities. You never know what's around the corner, do you? But I don't know what the future holds, and I've certainly got no plans at all to embark on another career, given that I'm very shortly, in fact, I'm going to be 60, and so no, it's getting those sort of questions is humbling and very nice, and I'm very grateful for the ongoing support that particularly patients that I've been fortunate enough to look after, but also people that have posted very positive things as a result of these interviews. It means a hell of a lot, and I think without that, particularly around the employment tribunal and when the result came out, that level of support through the Facebook group was incredible to get, and I think without that, I would have had a very different progress through this, really, which has been and to a certain extent continues to be a complete nightmare, really.
Absolutely. I mean, it's horrendous. I don't know what else to say about it, really. I mean, I know two people that have been through the same thing, Stephanie as well.
Yeah.
And I mean, I don't want to speak for her, but she arguably is in a worse position because she is younger and I mean, has just lost everything that she had, really. I mean, I say I don't like to speak for her. It's really for her to say that, but it's awful for me to see, and I do feel that that's yet another reason, along with everything else, that is so important about this case, why I should try and help and try and do something to raise awareness. Because what you were describing, where you raise all not, I mean, the fact that what you said was validated by the Care Quality Commission, for example, but then that was just brushed away because they don't want to, for whatever reason. It doesn't even matter why it was brushed away. The fact is, it was brushed away. That's it's calamitous culturally, isn't it? It's utterly calamitous. Especially
Well, these are the individuals that brushed it away were the most. I won't mention any names or what their positions were, but they were the most senior managers in the organisation, and of course they were fundamentally critical 2 years down the line in being instrumental in securing my exit from the organisation, and that certainly wasn't a coincidence. And then when so it was about 2.5 years after I whistle blew, CQC descended on the trust, at which point we had a good rating, I think, for maternity. And every single issue that particularly around the midwifery staffing and dangerous staffing levels, again, very, very relevant to the cancer suggested. Every single issue that I raised concerns about, they vindicated. And then when the condemning report got published, and the trust was then plunged into requires improvement, and we were even placed on the NHS England maternity improvement programme, those individuals, when they're interviewed by the local TV station, denied that they were issues that they'd known about, even though I've got documentary evidence that I warned them and other members of staff warned them about the full 2.5 years later. They said it was all news to them, all news. It was, and we've learnt our lessons, and we've the same bullshit that the NHS senior management recurrently push out, that we've learned from this and we've made the necessary changes. Well, you knew about them 2.5 years earlier. And the critical thing with that is, had they have taken action when they initially knew about it, would some of the cases that happened, adverse outcomes that happened in the interim, been avoided? But it's that one of the critical issues about this maternity review that's going on at the moment, and whether or not Wes Streeting elevates that to a full public inquiry, is none of this is going to improve unless there is accountability at the top. However unsavoury that is to suggest, but until you have managerial accountability for this sort of thing, nothing is going to improve. You're going to get the same cover-ups, the same And what happened to Stephanie is identical to me. You know, she took on the monolith that is the police force, and look what happened. I took on the NHS, and look what happened. And all these organisations know what they're doing. They know they absolutely knew with me there is a playbook that they adhere to, and they know that by doing that, and they did exactly the same with Stephanie as they did with me, they know that there is a pretty good chance that they will destroy you. And if they don't, they'll leave it to the completely corrupt, broken, and unfit for purpose employment tribunal system to do it for them, which is what happened with both of us. And I was protected to a degree in mine because I had legal representation. Stephanie went into it as a litigant in person, so she didn't have that. And you know, I'm not surprised that she couldn't cope with it because it is brutal, brutal. Yeah, Stephanie is you know, kudos to her really for coping with it, to bounce back from the pit of despair that she got into, which was, you know, far worse than the psychological consequences that I was forced through as a consequence of all of this. And she's now, you know, bless her, doing everything in her power to try and influence this and to make positive differences for other people. So, you know, huge respect for her.
Yeah, I agree completely. So I don't know if that's a good place to leave it, but it's a poignant place to leave our interview today. So we've done a good nearly 2 hours. So we'll be doing many more of these because I've got dozens and dozens of questions left before I even ask for any more. And I've even researched, I didn't really make much of an effort to add to the list myself. So it's been really great to have you again. Thank you for sharing your knowledge and expertise so generously. We really appreciate it. And we'll get you on again soon.
It's always a pleasure, and I hope it's been useful.
Yeah, absolutely. Thanks so much.
Cheers,
Cheers.
Chris, and happy New Year to everyone again.
Yeah.